don't blame me for that title. My dyad partner, Dr. Tom Noseworthy, and I are very pleased that you were able to join us today. Today is a celebration. It's a way to say thanks to some phenomenal work that our organization has done through the clinical networks. And it's an opportunity to take that strategy and talk about why we're going to transform those clinical networks into strategic clinical networks. So we have 3 leaders here today that are going to talk to you about that transformation. I'd first like to invite up Dr. Chris Eagle, our President and CEO, who's going to give welcoming remarks from Alberta Health Services. Chris?
Thank you, Tracy. I didn't go to medical school at the University of Alberta, but I have the feeling that I'm in medical school being in this room. Some of the rooms have very good blind spots, so you can actually sleep behind a roll. And I know there's somebody sitting on the very back row, and I kind of wonder why that would be. But Tracy, thank you and good evening to all of you. I appreciate everyone taking the time to be here tonight, and I'd like to thank the members of the 8 clinical networks who are here with us tonight. And congratulations to each and every one of you on the amazing work you have done. This is a very substantial change for Alberta Health Services, very substantial change for healthcare delivery in Alberta, to take the learnings that came out of things like the bone and joint pilot, the cardiac network, the stroke network, and use those learnings province-wide across all of our operating units. So this is a very significant investment, it's a very significant opportunity, and there are a few places in Canada that can do this. There are places that have done similar things. If you think of Cancer Care Ontario, it tries to do the same thing. It's a province-wide network of facilities and programs that bring together people of expertise to learn about how to deliver the best healthcare. So we have some precedents for this. There are many places in the UK and in the United States that use clinical networks to actually improve quality of care. So we're not the first to do this. We're not the second, but we are the first here to do this. And the opportunities here in Alberta to build these clinical networks are second to none. I would especially like to acknowledge the patients that are here tonight. Their contributions to the design, the priorities, the future of these clinical networks is profound. So I would like to thank each and every one of you for the efforts that you volunteered in terms of helping us choose the right path. Alberta Health Services' goal is to provide patient-focused healthcare, and this cannot be done without involving patients, frontline staff, and physicians, and also communities. We have to involve everyone who will be infected by the decisions that we make. This is really a partnership to deliver the best care. The networks we're sharing the successes of tonight include addiction and mental health, bone and joint, cancer care, cardiac, critical care, emergency, surgery, and respiratory. The success stories that these networks have had is shown on the bulletin boards, the poster boards that are outside this room. And I encourage you to spend some time with not only looking at those posters, but actually talking to the people who led these networks. They tell you about the enthusiasm that people have, the chance that people have to make change in the way care is delivered in this province, and the ability to build momentum in these clinical networks so that we are able to deliver the best healthcare possible to Albertans. Through this type of teamwork, we can find new innovative ways of delivering care in Alberta. Teamwork helps us deliver on our #1 priority, which is ensuring the best quality of care for Albertans. As Canada's only provincial health authority, we have the unique opportunity to improve access, innovation, and bring expertise from across the province to provide this new pathway approach to delivering care. Through the province-wide networks, we can better link our strategic, clinical, and operational teams together. By connecting teams of people across the province, we can better engage clinicians and physicians, our partners and patients to help capture new ideas in a bottom-up approach to healthcare delivery. We're often beset with large-scale organizational change. We're going to have health regions. We're not going to have health regions. We're going to have one health region. We do a lot of work in Alberta looking at redesigning the macro healthcare system. This is a chance to invert that pyramid and look at what really are the needs of patients, clients and their families. How do we build the best patient care, put that first? Not the structure of the healthcare system, but the best way of delivering care, make that first. In order to do that, frontline staff must be involved and are heavily involved in developing these networks. Through the province-wide networks, we intend to set priorities and define the means to achieve them, and to focus the resources that we have much more sharply on the health needs of Albertans. But it's not only about delivering services and patient care, equipment, all of the things that we need to do like that. There's another opportunity here, and we've worked very closely with our academic partners so that we can support research, so that we can support education, so that we can support networks with our academic partners. The Canadian Institute for Health Research has an application called SPORE, which is about patient-oriented research. The things that we're doing in these clinical networks lines up exactly with the sentiments that led to the development of this national funding program by CIHR. You know, those are the kind of opportunities that open to us as we build the strategic networks, but as we link with our partners in this province, so we look at them not only in terms of improving care, but improving the research and academic background that supports that care. It actually supports the recruitment activity for Alberta physicians, for Alberta nurses, because this becomes a very exciting place to deliver health care. The teams have also looked at the journey that a patient would take going through this system. My office gets many, many calls from patients from across the province, patients, families, many people concerned about where they are navigating this complex healthcare system. One of the things I learned from the bone and joint pilot was that patients who went through that pilot really appreciate the fact they knew where they were. They knew when they hadn't seen their physiotherapist. They knew when they would see their orthopedic surgeon. They knew, as well as the providers, what the steps in that care process would be. That clarity of information does two things. One, it creates confidence in the system. And number two, it creates a safer system, because our partners, our patients, are actually telling us that they didn't get the step that they expected. That degree of engagement of our patients, I think, is really where we need to go. Patients need to be partners in this healthcare system, and one of the goals of the strategic clinical networks is to encourage that level of integration. The other part is it creates an understanding that's province-wide. So it's not that you get one type of bone and joint care in Edmonton, another type of medicine hat. There's a team that's put together the best way, the Alberta way of delivering this care. So whether you have congestive heart failure or stroke care or wherever you are in the province, you will get the best quality care, and you will know that it is standardized. You're not receiving second-best care because you're in a certain facility. You're receiving the best care. And who tells us it's the best care? It's the clinicians and frontline staff. So the strategic clinical networks will look for pockets of innovation and make it easy to share those innovations quickly province-wide. We've seen this in the past. We've seen some sharing. We've seen enormous progress made in the treatment of myocardial infarction in this province. But those sharings were not truly province-wide. Calgary and Edmonton did well. Other parts of the province did not. The network's approach is to make sure that all Albertans, wherever possible, receive the highest quality care. And that's really important. So today we have 6 strategic clinical networks that are getting started. They are addiction and mental health, bone and joint health, cardiac care, cardiovascular health and stroke, obesity, diabetes, nutrition, seniors health, and these 6 clinical networks will be joined by others coming. Networks that deal with things like complex medicine, maternal health, newborn, child, and youth health, neurological disease, primary care, and population health. So there's about 6 more networks we have planned, but we will adjust the implementation of the further networks based on the experience that we have with the first 6. We also have operational clinical networks. Many people have put a lot of effort into working to improve emergency care in this province, working to improve surgical care in this province, and so those working to improve critical care in this province. Those networks will continue. They've done great work, but their issue is more focused. With the strategic clinical networks, we're really looking at life to death. We're looking at onset of disease to rehabilitation or death. With the operational networks, it's more of a slice in time. You know, what is the best way of having surgery for hip surgery? What is the best way of providing emergency services in this province? What is the best way of delivering critical care? Those areas affect many, many of the clinical networks. But specifically, we have to make sure that those areas are delivering the best care too. And there's lots of worldwide information that we can bring into the networks spread across the province. Things like the critical care network that's being developed will help standardize critical care across the province and will help provide support to all of our critical care physicians, staff, and the patients who go through those units. So tomorrow, the first six strategic clinical networks and the operational clinical networks will be meeting to launch their new programs. Some of the work started by the clinical networks that started about 3 or 4 years ago will continue. Some of it will be new. All of it will help Alberta Health Services deliver the best patient care. And all of it is built around the premise of bringing innovative new ways of delivering care to Albertans. And I mean all Albertans. So thank you to everyone for coming out tonight. Your support in building a safe, high-quality healthcare system is very much the rallying cry for Alberta Health Services. I look forward to connecting with you directly as we go forward in this new vein with the strategic clinical networks and building a stronger, safer, and better health system for Albertans. So thank you very much, Madam Chair.
Thank you, Chris. You know, a couple of years ago when we started the clinical networks, we knew there were 3 things that we needed. One was we needed engagement, and the vision was that the networks would be a vehicle for engagement. But in order to do that, we also needed teamwork, and we needed those teams to be led by strong leaders. And Dr. Eagle was there among us, starting the clinical network several years ago, and he's with us today to help launch the strategic clinical networks. And we're really fortunate to have his leadership. We had it back then and have it today, and moving forward as we take this step in our history, which is pretty insurmountable to any other health authority in Canada. So Chris, thank you for being there with us and sticking with us. I'd now like to introduce Dr. Tom Noseworthy, who is my dyad partner and the Assistant Chief Medical Officer for Strategic Clinical Networks and Clinical Care Pathways. And Tom is going to spend some time talking about how do we transform from the clinical networks into the SCNs. And what's that learning platform all about? So Tom?
Hi everyone. It's a long time since I've been in this auditorium, and there are a lot of faces here that I'm happy to see. In fact, I'm happy to see all of you. I'd like to add my thanks as well to Dr. Eagles for the patients that are here, largely because some of you I know are going to become core members of our new strategical clinical networks. Some of you have been trained in research and are going to be even more valuable contributors besides your patient experience, so delighted to see you here. I also want to add my thanks to Dr. Eagles for the network activities that have gone on thus far. We have a history. We have 2 or 3 years of record of what could potentially get done if we can really take these to another level. We've seen what engagement can look like through such networks. And we've seen the early signs of how we might be able to achieve better outcomes for patients through improvements in clinical practice. Dr. Frank and I are going to present 2 20-minute sections that are complementary. We're not going to address the topics we've been given. Well, we kind of will. But I kind of want to lay out the proposition in certain respects for why we're doing this, and won't really say very much about networks at all, frankly. I'll leave that to Cy, who so ably will do that for us. And I just want to say it's been an absolute bonus for me for the last year to work tightly with Cy Frank and Tracy Wozlik, amongst many others, David Migran and Bill Trafford particularly, to get us to the stage where we are now. So this launch is really important from my point of view. It's serious business. I think we have unequivocal support from our board, from our executive, from our CEO. So we got to get it right, And I don't think we have a large window of opportunity here, and there's no time for complacency. Let me take you down a path of some of the issues that we actually face. Not infrequently, we start with the money side of things. It's too cluttered when we put all 10 provinces up there. I didn't want Newfoundland's graph to be taller than Alberta's anyway, which it is up around that end there. But Alberta is preparing itself now, and I've heard several times today at our meetings, preparing ourselves for 4.5% increase. How are we going to deal with that, given we've enjoyed higher increases in the past? And I just want to say, as all of you, whenever we travel outside this province, there are a lot of other places that are green with envy to know that we're having 4.5%, and we're starting to fear the worst because we have 4.5%. And that's the graph, and we won't continue to have 4.5%, would be the prediction. I'm not going to pick on surgeons that are orthopedic surgeons, but why not? Why not just a little bit? This is not a pick on. You draw whatever conclusions you wish for the many graphs I'm about to show you. The point I want to make is there's a change going on there, an increase in the infection rate associated with hip surgery. So what's really going on? Is this good? Is this bad? How bad is it? Is it comparative? Is it valid? I'm going to show you a number of things tonight, and I'll let you perhaps form your own judgment as to whether or not we have issues we want to address, because I think the whole reason why every single one of us is here, I would predict, is that we think that Alberta can be the best healthcare system in Canada. There are parts of it that already have that capability and that track record. But there's absolutely no reason why Alberta can't leapfrog now and be the best in all outcomes. We're not now. Let's take a little look through some places that are interesting. This is our Alberta diabetes prevalence, and whoever is looking after lights up there, just a little less without getting us too dark, might make it easier to see. We have the boys in blue, and you can see the bulge. And that's an important statistic for all of us to pay attention to, and we actually have one SCN that's going to be very focused on that issue. Here's diabetes prevalence by zone. Common issue. Good reason to have a diabetes, obesity, nutrition SCN. Let's move on and remind ourselves where we came from. No flashbacks, anybody, but you know, Alberta healthcare system to a certain extent is kind of a little bit like a work in progress. It changes from time to time. Sometimes they're marginal changes, sometimes they're quite cataclysmic. You remember many of those events, no doubt. But we formed in 2008, and now I would submit the intention here is, can we become the best performing healthcare system in Canada or not? Some of the things that are there were not the subject of the kind of thought that we would necessarily undertake ourselves. Some were politically motivated, some were best for the citizens for Alberta, but this is the healthcare system that we actually have. And this is the one that we have to make work. And frankly, what it really is a third type of healthcare in Canada. So just reflect on this experiment that's going on in Canada, not designed, it's kind of more natural than anything else. We really have three healthcare systems types or models now developing within the larger tax-funded model in Canada. We have the regionalization approach, which started back around 92, 93 in Saskatchewan and then caught on in Alberta and elsewhere. We have institution-based governance, which is a code for saying Ontario never really did reform its healthcare system and now it's brought in LHINs. Well, every hospital still has a board of governance, and it still has its own management. University Avenue still looks the same. The fiefdoms are exactly the way they always were. Maybe that's the right way. And then they've now got LHINs. And then it's our way. And our way is different. When we go to other provinces, people kind of are a little curious. Saskatchewan is scared to death. They've gone from 30 districts down to about 12, and they're worried that somehow or other government is going to reduce them to far fewer. But we have a natural experiment going on in Canada now. What metric would you use to decide which is the right way to go? Maybe more than one way is the right way to go, but the metric is patient outcomes. So the mandate of AHS is, in effect, in my view, the mandate of the new strategic clinical networks. Same thing. It's about populations and their health, and it's about the best thing that we can do for people that lose that health and become patients. Simply put, best outcomes, highest quality care with the best value for money. And I would submit that AHS's success, now that Chris has left, and we know he had to be back to Calgary tonight, by the way, AHS's success, in my view, in this window of opportunity is based on the success of SCNs. Or let me say it a different way. If SCNs are successful, AHS will be. And then there's another way of saying that, and I won't. There isn't an option to fail. This has to work because AHS needs a mechanism where the people that look after patients start driving the important things that this organization stands for. And ensuring value for money is going to have to become important to people at the bedside, and ensuring quality care has got to be important in the administrative rooms. How will we do this? This, in my view, needs to be clinically driven. Psy constantly uses the term bottom up. That's a little unfortunate, perhaps, terminology. But you know, if you came down from space and you looked at Alberta Health Services today or recently, what would you see? You'd see really, really well-intended, highly motivated, very hard-working individuals that come to work and administrate every day. And I know how hard they work because I've now seen that. And then you'd also have an entirely different group of people that went to work every day, as they always have, and do many of the same things they always do and are looking after patients. And this organization now is so big, we have the question, are the two properly connected? Is the 14th floor of 7th Street Plaza connected to what's taking place at the bedside? And is that realistic anyway? And if you wanted to make it realistic, how would you kind of do it? Well, the only way to do it is you got to get the clinicians involved. And somehow or other, the things that take place in the minds of the people that look after patients, whether they're nurses, doctors, physiotherapists, or otherwise, have got to influence what our priorities are and how we spend our money. And it'd be reasonable to say that that's not the way it is now, and it would be reasonable to conclude that if we can bring in some clinically driven change, driven by measurement, put in things like proper pathways for care, then manage the variance around those pathways, we have some of the ingredients necessary for continuous professional improvement, whether it's doctors, nurses, or otherwise. Look at this kind of variability. I just want to show a bit of variability, and I want to thank Stafford and all those wonderful people at Dimer that can produce this kind of stuff. It's valid, it's solid, it's good content, and I want to thank Tom for the good work that he does on measurement, and hope he doesn't get too far away from the analytic path. But MRIs, what would you conclude from this as you look at that graph? Does BC do too few? Sorry? Now click to go back. Yeah. Thanks, I got it right. There's BC. Great. I'm going to use yours. Low tech. Cy gave me this if I looked like I was screwing up. Okay, there's BC. This could be serious. BC, Alberta. Why would Newfoundland have half the number of MRIs per 1,000 population than New Brunswick? Is it the Miramichi River? I mean, what would it be? So I don't know what any of that variability means, but I just put it up there because I'm going to show you some slides of variability, and I don't want to be too interpretive. I want you to put yourself inside them and ask yourself what you think some of those things actually do mean. This is complex. Okay, each graph is a zone, or each set of histograms is a zone, and you got first, second, third, and fourth quarter of 2010 and then you've got the first quarter of 2011. So each one of those are a zone. Keep this in my hand. Where's the red guy up there that was pressing it before? Okay, look, each one of these is a zone. First, second, third, fourth quarter of 2010, 2011. Okay, just look across. You can pick that to that to that to that to that to that. You could talk about the variability within the zones. This is children that receive their mental health treatment within 30 days. You could say, what's going on with that kind of variability? You could say, what about that compared to that? There's a lot of ways you could look at that graph. I wouldn't want to be judgmental in the least, but what you can say is that has many different messages. It does show variability. So let's look at a bit more variability. But first ask ourselves, what's acceptable? What's acceptable? And we've learned a lot from accountants in terms of variance management. There isn't an accountant around that doesn't use financial variance as an indicator to look for opportunities to improve management. We haven't been doing that very much in clinical practice, not in this province and really not in this country, even though it has roots not far from here. Variance, certainly for financial people, points to an opportunity to manage or at least to examine why that exists. Maybe that could do the same thing for us in a clinical sense. And in fact, clinical variance management is what that's really all about. And it really needs solid health informatics and needs solid clinical analytics. And that is starting to develop in AHS quite nicely. Not nearly enough talent. And some of the talent is hiding. And we need to get it all connected. But the basis for being able to do clinical variance management is that you've got trusted data that is comparative across zones and eventually across providers of care and is done diligently, sensitively, carefully. Because if I don't get as good an outcome from my arthroplasties as Cy, I'm prepared to hear about it, but I need to hear about it in the right way, or I won't change my practice. I'll hide. So variance management is really important to us, and we haven't been really seriously engaged in it. And some variance is justified, some variance is not justified. Whenever unjustifiable variance occurs, usually it has a consequence to a patient or a consequence to the bottom line. And so it's important that we start thinking about this as we launch networks because they can be part of the way that we address this. Let's look at some data. Let's look at everything here I'll show is in the public domain. I absolutely am not trying to show any particular zone or particular place or practice or specialty group. I'm not signaling out anybody. This stuff is available in the public domain. Go look for it yourself. I just took out a few of these to see if we could start getting used to accepting that we have variance, attempting to explain it, and getting rid of the unjustifiable stuff. First, I got to change it. Back. Okay. This is an important one. Premature mortality. How quickly do we die? Look at it yourself. Get used to orientation here. The gray bars are zones. Forget which zone it is. That's irrelevant. The green bar is the best place in Canada you can be. How are we doing? Maybe some opportunity for improvement. Premature mortality means we die before we should have. Look at that. Maybe that's part of the explanation. Injuries. We know where those injuries are taking place. We know what some of the causes are. We know them by zone. Injury hospitalization. So we have a lot of different ways we can look at data. There's a lot of variability. What can we say? We got a lot of premature death in Alberta. There's a lot of variability by zone, a lot of injuries out there. 5-day in-hospital mortality following major surgery. Not trying to show up to surgeons. What would that graph say to you? It says a lot of different things, but in terms of the best place in the country, here, which is in Ontario, The only reason why North Zone is not given that credit on this is because this has to be a large RHA, and I presume they assumed that the North Zone wasn't. But something is going on in the North Zone. Maybe it's the type of surgery. There's a lot of explanations here, but like something good is happening there. But look at this. Threefold difference. Is that justifiable or isn't it? Don't know. Are the lights going up and down because people want me to finish? I'm not finished. Waiting time for hip fracture surgery. You know, fix them quick or they don't do well. If they're over 65, they like to die. You don't leave people in bed after hip fracture. We actually have done some work on that. The question is, will we be successful in rolling it out? Will we?
Yes.
We should be, because when you leave people in bed after hip fracture, they don't do well. And you can see we are not necessarily the best. Back to major surgery there. I don't know how that happened. That's the hip fracture one. You see, we're not the best. We're not bad, but we could do better. This is becoming a pain. I'm all over the map here because of this thing, frankly. So I'm going to try to back up. Bear with me. Please. In fact, thank you. Whoa. Please, one more. 90-day readmission after hip replacement. Now, picking on orthopedic surgeons, there's room for improvement. Next one. Yeah, let's just... What's the right cesarean section rate for babies? That's a hot topic. I'm sure there's obstetricians in the room have a strong view about that. Are we having too many cesarean sections? Don't know. Next. It depends. Are we doing any VBACs? Wonder what goes on in Winnipeg. Maybe we should check. Next. 30-day medical readmission. Any room for improvement? The largest regional health authority there again was Winnipeg. Actually, we might need to take a look at Winnipeg. They got a lot of really good indicators in this year's CHI indicators. We need benchmarks. Next one. Mortality from preventable causes as distinguished from, next one, mortality from treatable causes. There's room for improvement. There's also variability. Next. Ambulatory care sensitive conditions. You shouldn't be put in hospital for these by case definition. We exceed the best in pretty well every place, some more than others, and I bet you can see why some of that variability takes place. There's a real good reason why that would take place in some places. Is it all justifiable? Is there any of it that should be changed? What's the right standard of practice? Next. Nursing-sensitive conditions. Let's not make sure no one is left out, of course. Nursing-sensitive conditions would be the things, they shouldn't happen if the nursing care is good. That's sort of the way I look at it. Things like pressure sores, urinary tract infections, and such matters as that. Might be some room for improvement there. Next. Acute. Now, doom and gloom aside, there's some places in some things that we do that there's no one better in the country. Look at this one. Readmission rate after acute MI. Who's the green? We're in it. Next one. Ooh, every time I do something like that, those lights come on. So, here's another one. Next one. 30-day acute myocardial infarction in hospital mortality. Green. Calgary. Next one. 30-day stroke. Green. Calgary. Wow. We're doing the best in the country in some of these things. We still have variability on some of them. I mean, for instance, if you took that green experience and generalized it to some of the taller bar graphs, you would see a difference of 50 to 60 patients per thousand in mortality. That's not insignificant. So there's zone variability that we can work on. We can compare ourselves against benchmarks in other parts of the country. And there are some places where we do better than anywhere else and should show the way. Next. So back to where I started, and let me finish. Variance points a way for us to consider, are we doing as well as we can? It certainly requires solid data, and I think we have to be really careful when we see stuff like this, that we don't jump to conclusions about what it means, that we're interpretive, we're analytic, we get behind it, and we understand where justification exists and where it doesn't. When you see unjustifiable variance, it costs us money, and patients are not better off, so we should stop it. And it's not that easy to stop. And clinicians will need to be centrally involved with this. And I would say specifically to the physician community, physicians need to manage those types of clinical variances and be able to deal with them in a professional manner. And we think, frankly, that the new structures offer that. Next. So why strategic clinical networks? Because we've had the experience from what we've had before, and we thank those of you in the room that have brought us to this point. Because we know from elsewhere, as Chris Eagle told us, we know particularly in places like Scotland, we know we've got to do better at engaging people that come to work every day to look after the patients and turn everything upside down. And it's a mechanism of enabling engagement. And last, therefore, this is the opportunity to get better outcomes, to improve clinical practice in terms of being able to do that, get better value for money, and get clinicians re-involved. And Sai is going to tell us exactly how the clinical networks are going to do that. Thank you.
Sorry, before Sai comes up, I just wanted to say thanks to Tom. I think one of the things that Tom very eloquently demonstrated for us is huge opportunity for us. It's huge opportunity for the clinicians, for us in administration, for our patients, and for our academic partners to come together and take advantage of this. And Dr. Sai Frank, who's our VP of Research, among many other hats and titles, is going to tell you a little bit about what you can expect, what we can expect as we unfold this strategy over the course of the next 2 to 5 years. Sai.
Thanks, Tracy. Good afternoon, everyone, and thank you all for being here. I actually think the lights in the room were going up and down because of the energy in this room, actually. Seriously, I perceived fantastic energy in what was going on before we came into this room, which is really what this is all about, is really engaging people and getting them excited about the potential we have in this province. So I hope you leave here today even more excited than when you came. I wanted to start with a bit of a skill testing question. So a show of hands, how many people here are members of a strategic clinical network? Hands up. Okay. So everybody who held their hand up is right on. Everybody who didn't was wrong, because in fact, you all are. You just don't know it yet. We won't be happy until we have 100% of Albertans feeling an allegiance, alignment to one or more of these strategic clinical networks. And that's your challenge as network engaged people, is to make that happen. So people really understand what you're trying to do, why you're trying to do it, when, where, why, and feel like they're part of it. That will be success. So it's pretty important for us to have a clear goal in mind and what success looks like. And we all need to agree that Alberta needs to strive to have a sustainable health system that creates the healthiest population and best health outcomes in Canada. That's partly with a focus on disease, but it's a lot of focus on health. And we all need to be on the same page with what that goal is. Our target is 100% of Albertans to be positively impacted by what we're doing. And I know that to do that, we need to work with partners. That's why I've got that on several slides that I'm going to show you, is that AHS cannot do this alone. AHS is a major player, no question, but it's not the only player. And I'm going to talk about a few of the other players as I go along here. I know there's some people that are a bit skeptical, saying, "Cy, you're dreaming in Technicolour. You know, this is never going to happen. You know, I've been working at this. People are working hard. How come we're not making progress?" You know, Dr. Noseworthy showing those slides show that, hey, we're not perfect, but we have a chance to be pretty perfect. And I don't think there's many places that could say that. So I say, nix to those who are negative about this. I say, get on board, because the train is leaving the station and you're all on it. Whether you want to be or not. Welcome to Alberta, the land of opportunity. And I swear to God, this is the only province, the only place, the only time where this could happen, and must happen, actually, to show proof of concept that we can do this. As Tom has already said, and as Chris said before him, we know this is possible. People in this room have already made a lot of this happen. You've been doing it for a number of years. Provincial care pathways, quality improvements of all dimensions of care, value for money has been created. There is potential for sustainability with a bit more focus on a few things. We also know it's possible to get people on the ground at the front lines engaged. A bunch of you have already been doing that for a number of years. In fact, the people love being engaged. They're excited to be engaged. They want to be engaged. They want to be proud of what they do. They want to be proud members of networks and pleased to be in Alberta Health Services and to get this feedback that they're making a difference in people's lives. That's why we're all here. They just are excited to be part of what you're going to be creating. Dr. Eagle already gave you the list of strategic clinical networks and operational clinical networks and the nuanced difference between them of strategic networks working on continuums of care and operational networks working on key services, functions at points in care pathways, so I won't dwell on that. Now, this is a mind-boggling slide that has 20 criteria of high-performing healthcare systems on it that were derived from 3 international conferences that were co-sponsored with Alberta Health Services and the Institute of Health Economics last year. These 20 elements were extracted from several days of deliberations of the world's experts. And I'm not going to read these to you, but I'm going to say that most of these 20 elements are embedded in the structure and functions of the networks that we're trying to create. And I would invite you all to look at these more carefully and use this as Dr. Eagle actually earlier today said, this is like the North Star of where we're trying to go. This is the touchstone of how we're going to know if we're making progress. So our goal is to actually emulate these 20 things in everything we do and see them embedded in our structures and functions. So what I'm going to do actually is talk about them indirectly by saying a high-performing healthcare system would find synergy of its parts. There is no system that has only one thing in it. It's going to have multiple parts by definition. The question is, how do you make the parts synergistic? How do you balance the needs of local with provincial? And how do you ration those things? And who actually makes those decisions? Well, somebody has to, and there has to be a mechanism of doing that. So by adding strategic clinical networks to the already somewhat complex space of healthcare, with geographic focus but provincial needs, we have an opportunity to ration these things in a way that nobody ever has, to have the best of both worlds, the best care locally and the best provincially. We need to have that in mind when we're designing our priorities, our goals, and our programs. So these concepts that are key strategies are almost cut and pasted out of those 20 characteristics of high-performing healthcare systems. And I'm going to walk you through a few of these with some metaphors and some graphics. But the mind-boggling beginning of this is we got to be clear what the goal is. The goal is to keep people healthy. That's the center of the target. How are we going to do that? Engaged, strong primary care, one of the principles. There has to be seamless access to specialty care. Let's call some of them strategic clinical networks that are purposely overlapping because they share design, functions, purpose, and priorities. And they share infrastructure, resources. They put patients at the center. They're working with evidence to make decisions. Now, I'm really going to emphasize this. You know, Tom referred to slightly pejorative term of saying bottom up. I don't care who's on the top or who's on the bottom, as long as we get the job done. And you can take that any way you want. No, seriously, most people in healthcare are actually, surprisingly, not AHS employees. They don't work for AHS. In fact, the public, the patients, the partners are not working for AHS. And in fact, most physicians are not working for AHS. Most are in what's called private practice, independent decision makers. So I want to put a focus on getting providers and patients who are not in AHS engaged in what AHS is doing. So when you're forming your networks, keep that in mind. Those are two of the principles of high-performing healthcare systems. Physicians and providers of all types are engaged, and the public and patients are engaged. They're part of it. They must be part of it. So I'm so excited that some patients are here today, because we're getting this off on the right foot. You have to build teams where people collaborate with each other to make this happen. You need focus. Again, one of the principles. So you can't do everything at once. You have to do a small number of things well. So we're challenging the networks to focus on up to 3 things. A Tier 1 project, a signature project, and a reassessment project that tries to eliminate waste, that eliminates some of this variance that Tom was talking about in the process. Any and all of these projects should and can and should involve research, if necessary. I'm going to end with talking about the opportunity we have in research. We're also promoting the idea of at least one major cross-cutting project of all of the networks. And that's, I know there's some ideas floating around already. Great opportunity. The issue is that how do you focus on a small number of projects and keep everybody engaged? That's a huge challenge, actually. Because if you focus on too many things, you leave everybody off the bus. And as we all know, there are competing priorities. So this is a huge challenge. How do you keep everybody happy and engaged? Well, you have to do it. And you do it through some principles. The principles, again, of high-performing healthcare systems is quality is defined. And you practice to improve quality. The 6 dimensions of quality are often chopped up, and people talk about access, they talk about safety, they rarely talk about appropriateness or effectiveness. We're kind of hyper-focused on access to the detriment of some of these others. They're all equally important. It's important we're on the same page. Now, one of the things that we're going to be introducing to the network cores is that we're going to be playing around a little bit with some processes of decision making that are not going to be too dissimilar to the Dragon's Den, if any of you have seen that on television, where people come in with their great idea and they usually about 10% of them leave happy and 90% get killed because they actually didn't have a very good business plan and they hadn't thought it through. So we're going to be playing around with those kind of tools in priority setting. We're also going to be advocating measurement of everything that can be measured if it can be done cost effectively in a timely fashion. So if we can do this in real time and provide feedback such as this scorecard from the Bone and Joint Network that measures all 6 dimensions of quality and is fed back to the providers every 3 months at 12 sites to inform their progress against their objectives, this can be done. We're going to measure to improve by establishing some targets and trying to hit some targets over time, like lengths of stay for joint replacements, which you can see took the better part of a decade to get down to 4 days, which is the international benchmark, but at least you can make progress. If you know what the goal is, you can do it. Now, I'm going to wrap up by saying we need to embrace innovation, which is one of the principles. We need to be clear what innovation means. That it's not just a drug or a device. It can be a method, a system, a service. It can be built within or procured from outside. There's lots of innovations. Most people are not looking for innovations. The networks are going to be mining for innovations. They need to be actively thinking about, holy smokes, these people in Lethbridge have figured out a new way of doing this thing. That's a best practice. We've got to spread that, and it's going to have huge impact. And some of it, in fact, might even be commercializable, which is, again, one of our mandates is a knowledge-based economy. There are other ways that you can actually create health and wealth that isn't as direct as you might think. Research will be embedded in each network, which is actually my job description. So we've gone through a big process, and the expressions of interest have gone out in your mailboxes. A scientific director is going to be hired in each one of these strategic clinical networks. And this is kind of a first, to have researchers actually supported by, embedded in networks to actively promote and develop networks of research within the clinical network. And I'm not aware that any other jurisdiction in any of those other countries that has networks has ever done this. And I am really excited about it. Our academic partners in the Academic Health Network are equally excited about it. We're talking to all of our other partners too. Alberta Innovates Health Solutions, Alberta Innovates Technology Futures, who are excited about the opportunity to eliminate these gaps in knowledge translation that are known to occur. A great idea usually gets lost when it gets into clinical practice because it was pushed by researchers on unsuspecting clinicians who didn't really want that anyway, so it gets lost. So we're going to change that paradigm. We're going to actually align the research push to the clinical pull. And the SCNs are going to be mandated to do that. What research needs to be done to improve quality of care in your network? Let's do it. Let's incent it. Let's make it happen. Let's do it with our partners in the Academic Health Network, funded by CIHR, AHS, AITF, and a bunch of others that will leverage our resources manyfold. So our structure is going to be a core team, many of you here, working groups, reaching out to the population. That big circle is all Albertans. So I don't want anybody leaving here thinking we are the network. that we're the beginning and end of it all. No, you're the beginning of it. Your job is to network the rest of the province, as I said. So you have lots of ways of doing that. Electronic, face-to-face, holding hands in a circle, whatever it takes. Your dyad leaders are champions. They're identifying other champions, building working groups of champions. And so it goes, where you engage all of the right people from all of the right backgrounds to make this happen, knowing that you need to balance needs and perspectives of some critical groups. Policymakers, administrators, patients, providers need to be balanced. They need to work in teams. And they need to be supported. This was the big difference in the transition to strategic clinical networks. They're going to be adequately supported to do what you're being expected to do. There are going to be some staff people whose job it is to make this a success, and some of these people are going to be shared purposely between networks to make sure there's crosstalk between them. Rowing in the same direction is possible. It's not easy. If you've ever watched any of these races, you know, they veer off course and crash into each other. So we got to finish here by saying, look, this isn't going to be easy, or it would have happened. We do have to manage expectations here. These things are not going to be transformative overnight. This is a journey of 1,000 miles, and we've taken the first step. So let's be real about how hard this is and how long it's going to take. But as long as I'm involved with this, and I think my co-conspirators up here, we should plan for success, and if the plan doesn't work, we're going to change the plan, but we're never going to change the goal. Because that's why we're here. Thanks.
Thanks, Cy. You can see now why Tom and Cy and I spend a lot of time together, because this is a pretty lofty agenda, and we couldn't do it with all of you being here tonight and continuing with us on this journey. I wanted to say that this ends the formal part of our launch this evening. In the room out in the hallway, there's still refreshments and some snacks. There's also all videos and all of the work that each of the clinical networks have done in the past that is up on the poster board. So I'd like to welcome you to go back to the foyer, network with some friends, sign up for one of the SCNs, and take some time to visit with your colleagues. But also take some of the information that is sitting on each of those SCN and clinical network tables, because there's some wealth of information that may be of interest to you moving forward. We have a lot of partners in the room tonight that Cy alluded to and that Chris alluded to. We have our partners from Alberta Health and Wellness. We have our academic partners here. We have our physician colleagues here. And we have our patients and our patient engagement researchers with us today. And tomorrow, we're all going to be starting orientation and getting a little bit more of what you heard today. So I want to thank you from our team and from Bill Trafford and Dave McGran, who are our leaders in helping support this initiative in coming this evening. I hope you enjoy the rest of the evening. We are here until 7. And please stop any one of us if you want more information. We look forward to working with you in the future. Thank you very much.